And it's an honor for me to do a faculty talk in front of such senior faculties, and some of my teachers also might be hearing this. And when Nisha Madam and Roshan asked me to do a faculty talk, I was pretty convinced that I should do something on coagulation, because I felt that that is one area where like our residents are not that much exposed to. Even though we have a good coagulation lab, our residents tend to not take lot of interest in working up coagulation cases. So that was my thought process behind taking a coagulation topic. And the specific topic that I took is isolated APTT prolongation. It can be a panic, puzzle, or pitfall, because it is one of the most common abnormality that we are going to encounter while sitting in the coagulation lab. So I have a series of cases. I hope I can finish my target. At least 5. There are 7 cases. At least I will be able to finish 5 cases, which are important cases that I felt on time. So let's begin with this number, seeing this number, and the topic is coagulation. Don't mistake it for plotting factor numbers. This is just 1729. Anyone know the significance of this number or the importance of this number? Maybe I can give a clue. Can you identify any personality? Who is this? Srinivasa Ramanujan. And this is Hardy, G.H. Hardy. And the number is known as Hardy Ramanujan number. And it's an interesting story. Like when Ramanujan was hospitalized, Hardy went to see Ramanujan, and Hardy was seeing somewhat dull looking. And Ramanujan asked, "Why you are looking a little bit dull today?" And the reply from Hardy was, he came by the taxi cab number that looked very boring. Okay, that the number of the cab was 1729. Immediately Ramanujan replied, "That's a very interesting number. It is the smallest number that can be expressed as cubes of sum of cubes of 2 different numbers in 2 different ways." So the reason behind this is like Hardy found a number very boring. The same number Ramanujan, who knew a little bit in depth about the number, found it extremely interesting. Okay, coagulation is something like that. Like when you look from the outside, it might be just lot of pathways and numbers. Looks a little bit boring, but once you get into the cases and start solving the cases, it is one of the most fascinating branches in hematology. Okay. So there are no conflicts of interest to declare. The cases I have kept it anonymous. And if you look at the evolution of coagulation theories, it all started in 1904 with a simple 2-step 4-factor theory. They only knew the conversion of prothrombin to thrombin and fibrinogen to fibrin. That is where it all began. Then later on, prothrombin time was discovered by Armand J. Quick. Then in 1947, Auren challenged this theory, 2-factor theory, when he was working on a patient, and he demonstrated that there is some other factors other than something involved in this 4-factor theory. Initially, there were very confusing names like Hagman factor, Stewart factor. There were a lot of named factors. Later on in 1958, all these factors were standardized into Roman numerals. And it is in the 1960s that one of the most widely accepted, the waterfall or cascade model by McFarlane and Ratnoff, came into existence. And they gave a very logical and rational explanation of how this fluidic blood is getting converted into a solid clot. So it's in a fascinating mechanism, and they somehow made a hypothesis and demonstrated that in the lab. So that is the waterfall model, which we all studied during the undergraduate days. It consists of 2 pathways, the intrinsic and extrinsic pathway. The basic concept of this is 2 pathways converge into a common point, which is the 10A activation. So the main aim of this 2 pathways is to generate 10A, activated 10A. Then it will it will act with 5 and will convert the prothrombin to thrombin, and thrombin will convert fibrinogen to fibrin. This is what is happening. And if you look at this, so you have one arm as the intrinsic arm and extrinsic arm. And you might have been aware of the fact that you have certain reagents to demonstrate the patency of this pathway, which is known as and that test is known as activated partial thromboplastin time, which will look at the patency of intrinsic pathway and the common pathway. Similarly, you have prothrombin time. You use different set of reagents using tissue thromboplastin. and you will look at the patency of extrinsic pathway and common pathway. So whenever there is a defect in common pathway, it will affect both PT and APTT. Okay. So a PT is normal means common pathway and extrinsic pathway is normal. APTT is normal means the vice versa. And there is thrombin time as well. We'll come into that in a while. So now we'll come. So based on this, there are equally important two pathways converging into a single pathway. Okay. Now we have a case scenario. This is a patient named A. This is a hypothetical scenario. 13-year-old male who has a prothrombin time which is within the normal range and a APTT which is grossly prolonged, 120 seconds. And that child is having severe bleeding manifestations since childhood. He is having hemarthrosis and psoriasis bleed as well. Now all of you, some of you might already been aware of this setting. This is commonly seen in hemophilia A, or it can be either of the hemophilia A or B. This is another patient B, same age, exactly same age and sex. Prothrombin time, almost similar. APTT, exactly similar. He is not having any bleeding manifestations and he was incidentally detected to have an isolated APTT prolongation. Okay. So PT is normal means your common pathway and your extrinsic is intact. Isolated APTT prolongation. So you already know common pathway is intact. So it has to be something dealing with the intrinsic pathway. Then the factors involved are factor 12, 11, 9, and 8. So two patients, similar APTT, one with severe bleeding, the other never bled in his life. So what exactly is APTT telling us? So when you look at other lab parameters, for example, elevated bilirubin level, the patient will have jaundice. So it can be directly correlated to a clinical manifestation, to a phenotype. But if you look at the APTT, exactly same APTT, entirely different presentation. Okay, one is not bleeding, the other is having severe bleed. So where is it failing to explain? So now if you look at this pathway, both the arms are equally important. Okay. So, but when you look at the clinical presentation, the patients with factor 12 deficiency are not going to bleed in their life. Okay. But factor 11 deficiency will have variable bleeding. Some will bleed severely, some will bleed mild. Whereas 8 and 9 deficiency, they are always severe bleeders. So if this was equally important, the defect in any of these factors might have caused defective clot formation. But based on the clinical presentation, it's not like that. Okay. 12 is not bleeding at all. Another thing is, factor hemophilia patients, A and B patients are having severe bleeding. Why can't the extrinsic pathway compensate for the lack of factors in the intrinsic arm? Okay, just like you are having two kidneys, even if one kidney is not functioning, the other can do the job. Why is extrinsic pathway failing to do so? Why can't extrinsic pathway create enough clot? So this is not getting explained by the waterfall model or the cascade model, and people started challenging. And some more queries, I said extrinsic pathway is not able to compensate for the bleeding in hemophilia. But the interesting part is the treatment for hemophilia, one of the treatment that we use is recombinant factor 7A. So we are triggering the extrinsic pathway to create clot in hemophilia. So that is quite confusing. We can't explain this based on the waterfall theory. So later on after around 40 years came the current model, which is the cell-based conceptual model. This is a beautiful paper by Hoffman. This is a cell-based model of coagulation and the role of factor 7A. So based on this hypothesis or on this model, the clotting mechanism is occurring only on cell surface. Okay, it occurs only on the surface of certain cells, and these cells are either a tissue factor expressing cell like the subendothelial fibroblasts or monocytes, or even injured endothelial cells. And also the other cell that is responsible for providing the surface for coagulation to occur is the platelets. Now let's see what is happening. So when you have an injury, the tissue factor expressing cell will express the tissue factor. It will combine with factor 7A, and factor 7A will convert the factor 7A and tissue factor complex will convert the 10 to 10A So this is exactly the extrinsic pathway. So that is known as initiation phase. So this is explained in 3 phases. The initiation phase is exactly the same as the extrinsic pathway that we already know. Now what this is going to do is this is going to create a small amount of thrombin. Okay, once a small amount of thrombin is created, this pathway immediately get inhibited by tissue factor pathway inhibitor. That's another protein that will inhibit this pathway and shut it off. Okay, so you have some amount of thrombin being formed and immediately the feedback will go and shut off the initiation pathway. So now you have thrombin generated. Now this thrombin is going to create all the subsequent activation. Okay, so thrombin is one of the most potent activator of platelets. So the thrombin will go and bind to the platelets through PAR receptors. Thrombin will activate factors 5 to 5A. It will act on 8 to convert it to 8A. It will act on 11 to convert it to 11A. And also during the initiation phase, tissue factor 7A complex can also convert some of the factor 9 to 9A. That is also happening simultaneously. That is very small amount. So now thrombin has activated all the cofactors. Factor 5 and factor 8 are the cofactors. That is all getting ready. You now have activated 11A as well. And platelet is also getting activated. So everything is getting prepared for a final burst of clot formation. So this phase is known as amplification phase. Now, as the platelets get activated, all the factors are also activated. Now, what happens? The 9A and the, so the 11A is already generated. The 11A is going to create more 9A. 11A is going to act on 9 to create more 9A, activated 9. This activated 9 will combine with already activated factor 8 to convert the 10 to 10A. This 10A will convert the prothrombin to thrombin. Finally, the clot is formed. Now, this is this thrombin is formed in very high volume. Okay, so initially it was a small amount of thrombin. Now a large amount of thrombin is being formed. Now you cannot see factor 12 anywhere here. Okay, so 12 is not at all required for the in vivo hemostasis. Why? Because in the initial waterfall model, 12 was getting activated by contact with the surface, contact with negatively charged surfaces. But that is not the case in vivo hemostasis. Actually, 12A is not required for the 11A formation. 11A is, or 11 is getting converted to 11A by the direct action of thrombin. So you don't need 12 at all. That is why factor 12 deficiency never bleeds. And the variable bleed can also be explained by, variable bleed of 11 can also be explained by this, because 11 needs, the duty of 11 is to create some activated 9. Now here in this pathway itself, there is some amount of 9 being formed. Okay, so you can generate some amount of 9 even without 11. So it will cause variable amount of bleed. So this is the picture in the Robbins. The Robbins mentions the exact same concept, but in a slightly different way. It is not mentioning as initiation, amplification, and propagation. It just mentions, it's just, but this is exactly the same concept. This is exactly what happens in the in vivo setting, and you don't need 12 at all. So coming back to the query, now the formation of 10A, for large amount of thrombin to form, the 10A formation should occur on the activated platelet surface. Okay, that is where all the 5, 8, everything is available. So the 10A generation occurs on the activated platelet surface. That is very important. If the 10A is getting generated in this area, in the tissue factor cells, some thrombin will be found, but it is immediately deactivated by TFPI, tissue factor pathway inhibitor. That is the reason why whenever you have factor 8 or 9 deficiency, the thrombin formed is not enough. Okay, so you need this loop to occur. That is deficient in factor 8 and 9 deficiency. Okay, so your amplification and propagation gets affected. So only very small amount of thrombin is formed, and that is not enough to create clot. That is why your extrinsic pathway is not going to compensate. But when we use high dose of factor 7A, when you use the high dose, some of these 7 can directly go and bind to platelet through the negative charge. Okay, platelet surface has negative charge. When the 7 is given in very high amount, it will go and directly bind to platelet and initiate this pathway on the plate. 10A generation is initiated on the platelet surface with the help of factor 7. That is how recombinant factor 7A is used in the treatment of hemophilia. Okay. So that is how it all began. 4-factor, 2-step theory, then the cascade model. Finally, we are now into the cell-based conceptual model. So when we look at the components that are involved in the coagulation process, you have the vascular endothelium, platelets, coagulation system, and the fibrinolytic system. Now we are going to concentrate on the coagulation system. Now this is a quote that I took it from Sugesh Nair sir. He used to say, coagulation testing that we do in vitro is definitely not entirely representative of in vivo hemostasis, because the most important part, the endothelial cells, is not assessed at all in the laboratory. So we are already crippled while doing the analysis of bleeding disorder. But we can arrive at diagnosis in the majority of the cases, but some cases we may not find explanations. So when you work up a case of bleeding disorder, the most important thing would be the history. And you can see there are 14 clinical manifestations. So this is the coagulation form that we currently use in our lab. And when there are 14 clinical manifestations that is being described, and the clinician is asked to put tick wherever applicable. And this is exactly, now these 14 clinical manifestations are part of a objective scoring system that is known as ISTH, bleeding assessment tool scoring system. Okay, you assign different scores for each of those 14 clinical manifestations to arrive at whether the patient is likely to have a bleeding disorder. So that is the application. This is freely available in the internet, and you can just take history based on this badge scoring. There are clinical manifestations, 4 points, and the maximum point will be 56. Okay, so what is the application of bleeding assessment tool? So the cutoff, score cutoff is different for adults and the female, male, and the pediatric cases. And the main role of this tool is to how to rule out a bleeding disorder. Okay, so suppose a lady is coming to the gynec OPD with menorrhagia. She's not having any other bleeding manifestation. Now the clinician wants to know whether, so all the screening investigations were normal, but now clinician wants to know whether we should go for advanced costly analysis like von Willebrand analysis, von Willebrand factor analysis and all. So in that setting, when the clinical suspicion is low, this can be used as a tool as in having high negative predictive value. When the score is low for females, when the score is less than 6, that says this patient is unlikely to have a bleeding disorder. That is when the clinical suspicion is low. Already the clinical suspicion is low. But when the clinical suspicion is high, that means if there is a significant family history, or if any of the screening investigation was abnormal, then this bad score is not at all used. Okay, you directly go with the detailed comprehensive analysis. Okay, so it is used as a rule out tool, which is having a high negative predictive value. Now, after the clinical history, no scoring, because it is difficult to score in the OPD, but we want the clinical manifestation. And the idea was our PGs to go back and ask the history and take the scoring. We are doing the scoring now. And the next important thing is the family history. That is another important history, because there are different or particular specific mode of inheritance for different bleeding disorders. Hemophilia A and B inherited by, what is the inheritance for hemophilia A and B? X-linked recessive. Okay. Then there are von Willebrand disease that transmit, most of the common von Willebrand disease transmit in autosomal dominant, except type 3 and type 2, and which will transmit as autosomal recessive. So family history and the consanguinity is important. So consanguinity is important, especially in the setting of consanguinity predisposed to what type of autosomal recessive inheritance. So you have to take family history up to 3 generations. Okay, at least 3 generations should come in the pedigree chart. After the family history, you have to ask the bleeding, the family, like If in a busy clinical OPD, it is difficult to draw the pedigree chart. So what we have done is we have just asked the history of affected males and females. Okay. So ideal thing is to draw a pedigree chart. Then the next important thing is transfusion history, because while doing the test, we should know what treatment was already given to the patient, whether he was given any FFP, because it will interfere with our assays. And any other previous test that is being done. As a screening test, there are few tests that we will usually do as a screening test for coagulation disorder to screen the primary hemostatic defect. The platelet and von Willebrand defects will be screened by, first you will take a platelet count and you will do a bleeding time. So this is the screening test for primary hemostatic pathway. For the secondary hemostatic pathway, you use PT, APTT, thrombin time, fibrinogen assay, and sometimes you may use something known as urea solubility test. We'll come into in detail. So we already know the role of APTT and prothrombin time. Now thrombin time. So what thrombin time? So there is always a misconception that thrombin time assesses the common pathway. It is not the common pathway that is getting assessed. It just looks at the conversion of fibrinogen to fibrin. Okay. To the patient plasma, we are providing exogenous thrombin, and we'll just look at the conversion of fibrinogen to fibrin. And it will get affected when there is afibrinogenemia, hypofibrinogenemia, dysfibrinogenemia, or when there is thrombin inhibitors like heparin. So these are the 4 tests that we usually do while screening the coagulation pathway. Now, the endpoint of PT and APTT, everything is fibrin clot formation. We are not assessing the role of factor 13 anywhere. Okay, factor 13, what it does is it stabilizes the fibrin clot. But in the endpoint of our assays is just formation of fibrin clot. We are not assessing the stability of the clot. Now that is assessed by something known as urea clot solubility test or factor 13 assay. So whenever all the 4 tests are normal, you need to do factor 13 analysis also, just to rule out secondary hemostatic defects. So this is an illusion picture. I think most of you might be seeing a young woman facing away from you. Is there anyone who is able to see an old woman in this picture? It is said that depending upon the age, you will see the younger, and or if you're old, you will see the old. That is what they say. Yeah, and if you have seen the picture before, you will see the old. So for those who have not seen the older woman, I'll just show. This is her left eye. This is her nose and mouth, and she is looking to the left, slightly down. Okay, now if you go back to the picture, you can make out the. It took a lot of time for me to identify the older one. So that is so we'll move on to our first case. So it's a 3-year-old male child with epistaxis. There is a previous history of epistaxis and bleeding from minor wounds. There is history of spontaneous bruises. And he was born out of 2nd-degree consanguinity, CBC and the platelet count. So this is the pedigree chart. Now, whenever I was getting trained in coagulation workup, whenever I take a case to my consultant, he will always say that your family history is not enough because you have not elicited any positive family history in this case. I don't know whether it's because of, it's an art to ask a lot of leading questions. You get to poke and get the family history. But I don't know whether it's the nuclear size of the incidence of manifestations running in the family. I don't know. But for this case, we couldn't elicit. So batch score was 4 out of 56. So for a child, anything more than 3 is significant. For a female, you have to be 6 or more. For a male, it has to be 4 or more to be significant, male adult. So for a child, 4 out of 56 is significant. You need further workup. So this was the initial screening test. PT was normal, APTT markedly prolonged. So whenever we see isolated APTT prolongation, so PT normal ensures that the common pathway and the extrinsic pathway is intact. Now isolated APTT prolongation means it has to be something in the intrinsic pathway. So before going into the further analysis, you have to rule out something known as heparin contamination. Now this heparin is known to cause APTT prolongation. Okay, because APTT is more sensitive to heparin. So for that, you can use thrombin time. So if the heparin is used, thrombin time will be prolonged. Okay. So you look at the thrombin time. If it is normal, that rules out. How does this heparin get into the patient's blood? It is through the venous access. Sometimes they flush heparin to keep the venous access patent. Okay, that is how it gets into the collected blood. Okay. So you have to rule out whenever there is isolated APTT prolongation, the immediate reflex will be to do a thrombin time to rule out heparin contamination. Thrombin time is normal, fibrinogen is normal. So now this is a true APTT prolongation case. So what next? Now we will do something known as mixing study to know whether it's a true deficiency of factors, or is it some other antibodies that is inhibiting the factors. Okay, so what we do is we take patient plasma, which is deficient in some factor. We will take normal pool plasma that is having all the factors in normal level. Okay, you will mix it so that whatever that is deficient in the patient plasma gets compensated by the normal plasma. So when it gets corrected, and you will do the APTT on the mixed sample. When it gets corrected, it is factor deficiency. If there is an inhibitor in the patient plasma, this inhibitor or the antibody is going to inhibit the normal factors coming from the normal plasma as well. So there won't be any correction. Okay, so that is the whole idea of mixing study. When we did APTT of the normal control or the pool normal plasma was 32 seconds. When we did the mixing study, it is 43.1 seconds. Now, initially it was 114.8. The normal range is 27 to 35 seconds. When we mixed, it came to 43.1. Now, how many of you think that it got corrected? Because it is still outside the reference range. So how many of you think it's corrected? How many of you think it is not corrected? Okay. So there has to be some way. There has to be some methods to look at the correction. One method is you just look whether it has come to the normal reference range. So that itself will suggest that it is corrected. But in our case, it was still outside the normal range. So in that setting, you need some other calculation. So there are different calculations with different cutoffs standardized across different labs. You have to validate in individual labs. So there is something known as percentage correction, where we look at so you need not mug up this formula. You just need to get the concept. I'll explain. So when you collect with this formula, you are checking how much the APTT got corrected as compared to the previous. Okay. So that is the percentage correction. And the cutoff is if it's getting corrected more than 70%, it is taken as a correction. Less than 58 is taken as no correction. 58 to 70 is in the gray zone. We don't know what it is. Similarly, you have other calculation, which is Rosner index. This looks exactly opposite to what we are looking in the percentage correction. So the easiest way to remember it is like percentage correction is a optimistic way of looking at things. Okay, it looks how much it is getting corrected. Okay, it's a positive kind of thing. You are looking how much it got corrected. Whereas Rosner index is a little bit critical. Okay, it is a pessimistic way of analyzing. That is how much problem is still there behind. Okay, so it's the entirely opposite. One is assessing how much it is getting corrected. The other is assessing how much residual abnormality is still there. Okay, so that is the basic difference between Rosner index and percentage correction. And for the Rosner, so if the Rosner index is high, that means there is still lot of residual abnormality. That means that could be inhibitor. Okay, that is why something more than 15 is taken as positive for inhibitor and less than 11 is taken as factor deficiency, 11 to 50. This cutoff changes. Some lab uses 10, some uses 12. That can be validated in on lab. Yeah. No, we are doing calculating this for individual cases. Yeah. Percentage correction, the technician itself will do and bring it. So now when we calculated the percentage correction, it is more than 70. So it's correction. And when we look at the Rosner index, it is less than 11. So there is no doubt it is getting corrected. So that has to be factor deficiency. So there is another way of mixing study, but some labs does this, some labs doesn't go for this. Previously, we used to do age serum and episode plasma. Now, most of the centers are not doing this. Something they do is they are mixing it with deficient plasmas. So when the patient is, suppose the patient is having factor VIII deficiency, this factor VIII deficient plasma is a plasma that has all the factors in normal level except factor VIII. So when you mix, suppose the patient is having a factor VIII deficiency, when you mix it with VIII deficient plasma and do the APTT, there won't be any correction because both plasma is deficient in factor VIII. So that is the logic behind this. What this help is like you can get an idea which assay you need to do. So half patient plasma, 1:1 mixing of patient plasma and factor VIII deficient plasma is not getting corrected. That means the patient is likely to have a factor VIII deficiency. It is getting corrected with 9 deficient plasma. So you know it is not 9 deficiency, it is some other deficiency. So that is how you do. When we did the factor VIII assay, it is less than 1%. Now the grading of factor VIII deficiency is less than 1 is severe, 1 to 4.9 is moderate, and 5 to 40 is moderate, mild. So what is the diagnosis? It is hemophilia A. Just to get an idea which assay you need to do instead of doing all the assay. Now there is a problem. This is a male child, that is okay. Usually hemophilia presents with deep bleeds. So that was not yet presented because it's 3-year-old, maybe deep bleeds have not yet manifested. Yes, sir, I'm coming to that. So the history was there was a consanguinity and there was no positive family history. Okay, so it's a consanguineous marriage, no family. Usually hemophilia will give positive history in the males in a skipped manner. As sir rightly pointed out, one thing that was missing in the screening test was bleeding time. Bleeding time is more than 15 minutes. Now, is it justifiable in hemophilia A? It can't be prolonged because in bleeding time, what you are looking is whether the platelet plug is formed or not. You are not even considering the coagulation factors. So bleeding time prolonged means that has to be something in the primary hemostatic pathway. So what could be the defect? Which primary pathway factor or protein with von Willebrand? So it's just a simple test. Like some labs still does this, but many labs are not doing this test. But it saves you from a wrong diagnosis. Okay. So this is no more hemophilia A because the bleeding time is prolonged. Now what you do? You will do von Willebrand assay. When we did the antigen and Ricoff assay, so whenever the von Willebrand antigen is less than 3, it is considered as severe defect. And Ricoff less than 1%, it's a severe von Willebrand disease and type 3. Okay, severe quantitative deficiency of von Willebrand is type 3. So just the simple bleeding time helped us solve the case. Okay. So I'm not going to the detail of doing the bleeding time. We can do it with the help of a template bleeding Lancet. It's a Lancet that makes uniform depth incisions. The important thing is this is not accepted. Fingertip not accepted. Some labs do it on fingertip. That is not at all standardized and not accepted. And this lancet is also not accepted. You should use a lancet with blade. Okay. It looks like a blade. Okay. It's a template device. When you press, it will create an incision with a fixed depth. Okay. So anyone know this man? Who is this? So this is Eric von Willebrand. So he identified the first. It was a difficult case for him because previously all were aware of hemophilia, but he found a child coming from Åland Islands in Finland who behaved slightly different from the hemophilia. He didn't have any deep bleeds, and also all the bleeding were mucocutaneous. And when he took the family history, both males and females were affected. So he thought it is different from normal hemophilia, and he called it as hereditary pseudohemophilia. Later on, the factor was identified and we now call it as von Willebrand disease. It can be either quantitative or qualitative. It can be inherited or acquired. It is estimated that 1% of the global population have VWD, but we see very less because many of them have mild manifestations. It's a complex molecule synthesized by megakaryocyte and endothelial cells as a monomer. It later get dimerized, multimerized, and they are stored in the Weibel palate bodies as ultra-large von Willebrand factors. And the high molecular weight von Willebrand factors are the functionally active one. Okay. And when you look at the function of the von Willebrand factor, it's a multi-purpose factor. It will bind to the collagen. It will bind to the platelet domain and acts as a bridge. Okay. So it has a different domains: factor collagen binding domain, platelet binding domain, and it also stabilizes factor VIII. So it has a, that is why you got, whenever the von Willebrand factor is low, the half-life of or the factor VIII will get degraded easily. That is why we got the presentation mimicking hemophilia. Okay. So that is the three different domains. And that's why to assess the functional role, single test won't be enough because there are different interactions. So you have different functional tests. You have the restostin cofactor assay, which will assess the platelet binding domain. You have the collagen binding assay to assess the collagen binding domain. You have the factor VIII binding assay to assess the interaction with factor VIII. Despite the complexity in the molecular and the functional aspect, the classification, phenotypic classification is quite simple. 1 and 3 quantitative defects. 1 is mild, 3 is severe quantitative defect. 2 is the antigen will be normal, but the function will be abnormal. So the 2 is qualitative defect. There are different subtypes. 2A, 2B, and 2M are associated with problem with the platelet binding domain, and 2N with the factor VIII binding domain. Here, no, we have not yet started, but we have given the request and we are planning to get it soon. Yes, sir. We're planning to get it. Okay, sir. Okay. For the antigen. Okay, sir. Okay. So it's a antigen assay is a quantitative assay. The generally accepted range is 50 to 200% or international unit per deciliter. 30 to 50 is considered as low. Less than 30, we'll diagnose it type 1. When it goes below 3, like in our case, it is type 3. Whenever antigen is severe deficiency is type 3. Now, blood group O individuals are usually found to have lower von Willebrand antigen levels. And the expected level is little bit lower in blood group O individual as compared to A, B, and AB. So there are other assays. The functional assay, just as said, platelet binding domain is assessed by restostin cofactor, right? And you need to assess the factor VIII activity because it is what stabilizes the factor VIII. Then you have collagen binding and factor VIII binding domains. Now the collagen binding domain, so the collagen binding occurs only when the high molecular multimers are present in the plasma. Okay, so you have different two defects, 2A, 2B, and 2M. 2 and 2B are characterized by absence of high molecular weight multimers. 2M will have high molecular weight multimers. Okay. 2M, so 2A and 2B will have defect or absence of high molecular weight multimers. So in 2A and 2B, when you do the collagen binding, due to the absence of high molecular weight multimers, this collagen binding won't occur. So you will get abnormal collagen binding assay. So that is the whole idea of doing binding assay. It is a surrogate to high molecular weight multimer. Now it is now they are recommending not to do Ristostin-induced platelet aggregation if the genetic analysis is available. That is mainly to diagnose type 2B. If the genetic testing is available, because the standardization of Ristostin is little difficult. That is why they are recommending directly go for genetic study when type 2B is under question. So I'm not going to the depth of that. It will take a lot of explanation. So this is the basic idea. Okay. Now we will go to case number 2, 7-year-old male who had no bleeding manifestation, no significant past bleeding history, no significant bleeding history in the family, posted for an invasive procedure, routine screening showed prolonged APTT. Platelet count normal, bleeding time normal, prothrombin time normal, APTT marked prolongation. So PT normal means common pathway and extrinsic pathway intact. APTT abnormal, you have to definitely look at the thrombin time to rule out heparin. If it is normal, thrombin time is normal, it has to be something related to intrinsic pathway. And the factors are 12, 11, 9, and 8. TT was normal. We didn't have thrombin time. The thrombin time was done from outside lab. In mixing study, it got corrected. And I don't need any formula because I know it is coming to the reference range. So I am not calculating anything. Factor 8 assay was normal. 9 assay was normal. These two were done from our lab because we have 8 and 9 assay. Now we advise, since 8 and 9 was normal, the next thing to rule out is 11 and 12. 11 was done from outside. It is again normal. 12 less than 1. So now the patient is waiting for a surgery. Yes. No, actually we can stop at 11. 11 is important. 12. Without, we can skip 12 because that is not required for. Not required, is not going to be. That is the reassurance that we are going to provide to the clinician. Severe factor 12 deficiency, but unlikely to bleed. Proceed with the surgery. Till 11, it is important. So this is the next illusion. This is known as molar layer illusion. So you can see lines of different length. It's apparently different length, but it's an illusion created by arrowhead aligning in different directions. Okay, the lines are all exactly the same length, but because of the changes in the alignment of the arrowhead, it is some are little short, some are little prolonged, like long. So that is the clue to our next case. 44-year-old male, again posted for hernia repair. Preoperative screening elsewhere detected isolated prolonged APTT, 120 seconds. No history of bleeding manifestation, no family history. Surgeon decided to repeat APTT. Now in another lab, it was a good lab, NABL accredited lab. It was coming in the normal range, 35 seconds. Okay. One lab, it was 120 seconds, and the other lab, it is 35 seconds. Not our lab, this is not our case. So it is referred for confirmation for the workup. So PT, normal, APTT, prolonged. TT, normal, heparin, rolled out. Mixing study. Yes, sir. That we'll come into that discussion, sir. Like that is the abnormality here. So mixing study with pooled plasma corrected. So it has to be some deficiency in the intrinsic arm. factor assays, all within normal range. Now it's a problem. Now in the cascade model, I didn't explain the role of two other factors, which is the high molecular weight kininogen and the prekallikrein. These are also not required for the normal hemostasis because in cell-based model, we didn't consider this all. But this is required for the contact activation system that involves 12 prekallikrein and high molecular weight kininogen. That is the contact activating system. So could it be prekallikrein or high molecular weight kininogen deficiency? But the problem here is there is a documented normal APTT at another lab. Now that is an issue. Okay. So if it was a deficiency, why was APTT normal at one lab and grossly abnormal at other lab? How to explain? How to proceed? Now there is something known as incubated APTT. Now you give some more time. Like usually we do for the contact activation to occur. What we will do during the manual assay, we will take the patient plasma. You will add the APTT reagent. You will keep it in the water bath for 3 minutes for the contact activation to occur. What happens? The reagent will be having activator like silica, ellagic acid or kaolin that will activate 12. 12 will become 12A. 12A will convert the prekallikrein to kallikrein. This kallikrein will amplify the 12 activation and high molecular weight kininogen act as a scaffold for this reaction to occur. That is the contact activation system that is going on. Now 3 minutes is given for APTT just for contact activation to occur. When you give extended time, what happens if prekallikrein deficiency? Now, I said the 12A is getting generated by contact activation. The 12A is going to convert prekallikrein to kallikrein and amplify. So prekallikrein just amplifies. Even without prekallikrein, there will be some 12A generation. When you give extended time, there will be more 12A generation so that when you give time, extended incubation time, the APTT value will come little bit down or shorten. For 12 or high molecular weight kininogen, there won't be any change. So the result of incubated APTT was 82 seconds. It was initially 110 seconds. So there is some shortening. So it is likely to be prekallikrein deficiency. Now again, why was the APTT normal at another lab? Now this brings us to the different reagent types that we use in the lab. Okay, based on the sensitivity of factor deficiency, sensitivity to factor deficiency and lupus, there are different types of reagents. Some are highly sensitive to factor deficiency, some are highly sensitive to lupus, and some are moderate sensitive to both. This depends upon the patient population that you are going to. If you are going to deal with a lot of rheumatology cases, you need lupus sensitive reagents. So that they is purely based on the patient load. Most of the centers use something that is moderate sensitive to both. And also, based on the contact activators, there are different reagents, silica, kaolin, and ellagic acid. Now, ellagic acid is peculiar because it is insensitive to prekallikrein deficiency because it directly activates 12. Okay, it doesn't require prekallikrein amplification to occur. So, ellagic acid, whichever lab is using the ellagic acid as activator in prekallikrein deficiency, there won't be any APTT prolongation. That was what was happening in our case. The other lab was using Siemens actin FS reagent that was having ellagic acid. Okay. So this was shared by my colleague. I thank him for sharing this case. Previous. Name. And the important thing is, as Sir said, after 8, 9, and 11, you can stop. You can just do this step just to know whether it's prekallikrein deficiency, but it is not significant clinically. Now, this is another illusion. So if you spend time, so initially it will look like some blotches, but if you spend some time, you will make out the Dalmatian dog in the image. That is Dalmatian dog illusion. So you need to spend some time on the image. So that is the next clue to the next case. This was a known case of hemophilia A, 35-year-old male, diagnosed from CMC Vellore. He's on factor VIII prophylaxis, presented with new onset intracranial bleed. So following which he was given little rigorous factor VIII administration was given during the intracranial bleed. Now it came for screening for inhibitors. Okay. And the last factor VIII was given on May 1st and the sample was received on 3rd May. Now usually when the patient fails to respond to the indications would be failure to respond and you need periodical monitoring and the highest incidence occurs during the first 20 exposure days. Little bit high risk for the first 75 exposure days. After more than 150 exposure days, you need less frequent monitoring for inhibitors. And another important thing is whenever the patient receives lot of factor VIII, just like in our case, when he had a intracranial bleed, he received lot of factor VIII during over a period of 1 month. Okay, whenever there is an intensive exposure to factor VIII, immediately you have to screen for inhibitor after 1 month. That is why in April that was finished and in May we got the inhibitor screening. We didn't do PT and all because it's an on case. We did APTT that was prolonged. Normal pooled normal plasma APTT is 30.1 second. Mixing steady, it is going correction. It is coming to the normal range. Percentage correction and Rosner index is saying correction. So that is factor efficiency, not inhibitor. But the problem with factor VIII is factor VIII inhibitor takes time to act. So when you immediately mix and do the APDT, the prolongation may not be evident. Okay, factor VIII inhibitor requires, it is a time dependent inhibitor. So it requires little bit more time for the inhibitory activity to take part. So for that we will do inhibitor screening. So what you will do, you take the patient plasma, you will take the control plasma, then you will take a mixture of patient and control plasma. You will incubate it for 2 hours. So that is, you are incubating patient plasma, control plasma and mixed plasma for 2 hours. So that basically what we are giving is, we are giving the normal plasma and we are giving the patient plasma that is having inhibitor enough time to neutralize the normal factor VIII that is supplemented by control plasma. Okay, that is what we are doing. So if there is inhibitor, immediately if we mix, it will be normal. But after prolonged incubation, if the inhibitor was there, it will be prolonged. Then we also do a fresh mix. After 2 hours of inhibition, we again do immediate mixing of both patient and control plasma. Now, the important thing is tube C. Okay. So, in an intrinsic pathway defect without inhibitor, there will be correction. And incubated mix also, there won't be any prolongation. Okay. It will still stay corrected when there is no inhibitor. When there is a time-dependent inhibitor, you can see in the incubated, so this was the fresh mix. So during the fresh mix, it was normal or it was corrected. But when we incubated and did the APTT, it is getting prolonged. So that means the patient plasma might have had inhibitors. Now, immediately acting inhibitor, both the fresh mix and the incubated mix will be equally prolonged. Okay. So whenever the difference between fresh mix and the incubated mix is more than 8 seconds, that is considered as inhibitor screen positive. Immediate acting, usually in factor VIII, the immediate acting suggests that it is going to be high titer. Okay, usually factor VIII is time dependent, but whenever you have an immediate acting inhibitor in a VIII deficient individual, that suggests that it is going to be a high titer individual, high titer inhibitor. It is just to differentiate between 9 inhibitor and 8 inhibitor. So 9 will be immediate acting and 8 will be delayed acting. 8 inhibitor. Now, whenever the inhibitor is there, lupus will be immediate acting. Lupus is also immediately acting. So the fresh mix will be prolonged. Delay and immediate. So clinically, when we have find inhibitor is positive, you have to do the Bethesda inhibitor assay, and you have to look at the titer of the inhibitors. Depending upon the titer, the treatment will change. If it's low titer, it will be, you have to just observe. When it is high titer, you cannot give factor VIII, you have to use bypassing agents. That is the ultimate aim. Factor IX, same process, but it will be immediately acting. So then we'll do Bethesda inhibitor assay. Now I am not going to go into the detail of Bethesda assay because it will take a lot of time. Basically what we are doing is, we'll take the patient plasma, which is supposed to have inhibitor, we'll pull it, we'll mix it with normal plasma so that the patient plasma inhibitors will act on the normal plasma and reduce the factor VIII activity. Similarly, you make a control sample using a sample that is not having any factor VIII, either a buffer or a factor VIII deficient plasma. So that it is exactly similar to the patient plasma. Patient plasma is deficient in factor VIII. You use another factor VIII deficient plasma and mix it with a normal plasma as a control. Okay, so then if the patient plasma is having inhibitors, that will inhibit and reduce the factor VIII activity, and the control mixture will have a particular factor VIII activity that is not having any inhibitor. Then you will just compare how much additional inhibition or additional reduction in factor VIII activity occurs in the patient mix as compared to the control mix. Okay, so if it is inhibition, the patient mix will be having reduced factor VIII activity as compared to the control mix. Okay, that is the whole idea. I am not going to go into the depth. So that is how you do Bethesda assay. Something you will assign the Bethesda unit based on certain calculation. If it is more than 0.6 or more than or equal to 0.6, suggests inhibitor. Now for this case, the Bethesda assay came it as 6.4. And the significance of it is, less than 5 is considered as low titer, and more than 5 is considered as high titer, and high titer individual will demand bypassing agents like recombinant factor 7A or FIBA or all those things. This is another illusion. This is known as the Herring illusion. Here, this will look like a bent line. Actually, these both are parallel lines, but the presence of background radiant lines is causing distortion or a distorted perception of the straight line. That is a clue to our next case. Again, severe hemophilia A, came for inhibitor screening. There was no recent history of any factor concentrate administration. Now, when we did the APTT, that is coming as normal. So this was a documented case of severe hemophilia A. No factor VIII administration recently. Now it is coming as APTT, completely normal. Severe hemophilia A, normal APTT, and no recent history of factor administration. That is quite a puzzling scenario. So what could be the reason? So we have to ask, so we went and asked the patient whether he received Emicizumab during the previous months. Okay, and patient gave the history of using Emicizumab almost 1 month back. Okay, so the Emicizumab was given to the patient 1 month back. What is Emicizumab? It is a biclonal antibody which mimics factor VIII. So what is the role of factor VIII is to bring factor 9 and 10 closer. Okay, so the yellow one is the factor VIII. It will bring factor 9 and 10 closer to create factor 10A. What Emicizumab does is exactly the same thing. It has binding domains for 10 and 9A, and it will create the, so it is exactly bypass the use in the role of factor VIII. Now Emicizumab is notorious to cause shortening of APTT because it is not even considering factor VIII. Okay. It will usually come within the, this is almost reached the half-life of, it is 1 month back. Usually immediately if you do the APTT after an Emicizumab, it will be definitely shortened. It was coming in the normal range. Can be normal or shortened. Yes. Actually, the half-life is almost 1 month. Some people require, it can be given even longer duration prophylaxis. So for APTT, so for the Emicizumab patients, the APTT, the normal APTT based assays are not valid because whenever you do APTT, it is coming to be normal. Now there is no point in, so our factor VIII assays are all APTT based. Now if the APTT is normal, definitely you are going to get factor VIII as high. But it is not actually factor VIII that is causing the clot. It is the Emicizumab that is present in the patient in plasma that is making the clot. Okay. So you need some other assay, which is the chromogenic assay. So this patient we asked to do the chromogenic assay from outside. So I'll just try to explain the chromogenic assay. So basically, if this is the normal scenario, if this is the factor VIII normal pool plasma and the patient plasma when we are doing the inhibitor assay, in the control mixture, there is no antibody and factor VIII is getting activated and converting into, this is the normal thing that occurs in all normal individuals. Okay. The normal intrinsic pathway based APTT. Okay. Here, what happens, the patient plasma is having inhibitor. It is inhibiting the factor VIII, but Emicizumab is, no, what Emicizumab is doing. So this is the normal one. Sorry, this is the normal one. So this is the normal APTT. Here, when we do the APTT based assay, so this patient plasma is having an inhibitor and is inhibiting, these green ones are the factor VIII. So the antibody is inhibiting the factor VIII. But when we do the assay, instead of the factor VIII, the Emicizumab is going to bridge this and give a clot reaction that is going to come at normal. Okay. So that is what Emicizumab is doing. But when we do bovine, so this Emicizumab will act on human factor 10 and factor 9. The binding site is compatible with human factor 10 and factor 9. When we use a bovine reagent, that the reagent that is having bovine factor 10 and bovine factor 9, the Emicizumab can no longer act. Okay. So the reaction has to be dependent upon the residual factor 8 activity. I hope you got the concept. Okay. That is the whole idea of doing bovine reagent. And in the chromogenic assay, you are not looking at the formation of fibrin clot. Instead, you are just looking at the conversion of 10 to 10A. This 10A will convert a chromogenic substrate and create a colored reaction that is measured at 403 nanometer in the machine and give a value. Okay.
Very difficult to understand, but just for a point of interest from the hematology department, they asked us to start this chromogen assay. So we've got this new coagulometer and one patient in a month.
Actually now, for chromogenic assay, actual cost I am not very sure, but we are getting supply to all the patients who are up to 18 years of age, free of cost. NHM, through NHM, getting free of cost, Emicizumab. So we are getting it free of cost for up to 18 years of age. Yes, it is in use. Yes, it had certain concerns with thrombotic risk, especially when it is used with APCCs, the activated prothrombin complex concentrate. That is the only scenario where this is contraindicated or it has a thrombotic risk. Otherwise, it is, and it dramatically reduces the morbidity, especially the joint bleeds and all. So it's a good prophylactic drug, but whenever there is an acute bleed, you have to resort back to factor VIII concentrates because it is a slow acting drug. So it is just for prophylaxis, not for an acute bleed. I hope you got the concept of a bovine chromogenic assay. So the patient went to Vellore, and when he did the bovine chromogenic assay, the factor VIII was 1%. So, and there was no inhibitor in bovine chromogenic assay. So coming to case 6, I'll quickly go to the case 6 and 7. 65-year-old male, anemia under evaluation, Corey, GI loss. That is, they are suspecting GI bleed. There was a history of epistaxis, hematuria, and GI bleed, all recent onset. So over these 65 years, this is the first presentation. And during childhood, there was no history, no family history. Batch score was 4 out of 56. Platelet count normal, PT normal, APTT was markedly prolonged, and the mixing steady, it is 52.2 second. When we did the percentage correction, it is 72%, slightly above the validated cutoff, that is 70%, suggests maybe factor deficiency, and the factor assay came to be less than 1%. Severe factor VIII deficiency, 65-year-old, first presentation, no joint bleed, no previous bleeds. So 1:1 mixing study, 52.2 seconds correction. When we did the Rosner index, it was showing slight. So this discrepancy will happen. Okay. So it's not like it won't agree always. Okay. There will be discrepancy between Rosner index and percentage correction. And Rosner index is suggesting inhibitor pattern. Now, for this, in an adult, first onset, hereditary hemophilia A, it's unlikely. So it has to be acquired. So we do just like the we do 2-hour incubated mix. Bleeding, we're not sure what's the exact cause. Yeah, we're not sure about the cause of anemia, but he didn't give any previous bleed history. This is all the recent onset bleeds. And Bethesda inhibitor assay was 64, quite high titer. We had suggested the possibility of acquired hemophilia A, and actually the patient was started on steroids. He responded well, and when we did the factor VIII assay, it came back to normal. So he's lost to follow-up, but immediate follow-up, this is what we got. He responded to factor VIII. In fact, responded to steroids. This is the final picture. It's a duck rabbit illusion. It's quite evident. All will be able to make out. So it's a 32-year-old female with recurrent pregnancy loss, recent episode of left lower limb swelling and pain, no bleeding manifestation, no family history, HB11 platelet on the lower limit, prothrombin normal, APTT slightly prolonged, TT normal, mixing study suggests there is no correction. So it has to be immediately acting inhibitor. The previous case, it was delayed acting. Here it was immediately acting. And the history is quite indicative of what this patient is having. Presence of an immediately acting inhibitor, likely lupus anticoagulant, and the recent onset of lower limb pain suggests possibly DVT, recurrent pregnancy loss, all indicates a thrombotic phenotype. So the lupus anticoagulant panel, the ISTH recommendation is to do 2 types of tests based on 2 different principles, that is DRVVT and SCT. So SCT or silica clotting time is nothing but the same APTT using silica as the activator. In the screening test, it will have low phospholipid content, so it is anti-phospholipid antibody, so that when we mix it with low phospholipid containing APTT reagent, all the patient anti-phospholipid antibody will bind to the phospholipid, and there won't be any phospholipid surface for the coagulation to occur. That is why the bleeding time in the APTT is getting prolonged. Now, to confirm the phospholipid dependence, the next reagent that you are going to use is a reagent that is having very high amount of phospholipid that will saturate the antibody. And you will be having still some phospholipid left out to bring the reaction, to bring out the value to get corrected. Okay. The next method that is used is DRVVT. So this is basically APTT using silica as the reagent, but using 2 different concentration of phospholipids. In DRVVT, DRVVT act on factor 10 directly. So it bypasses the role of all these factors. Okay. So it will directly act on factor 10 and bring out the reaction. Again, in DRVVT also, you have high phospholipid and low phospholipid. During screening, you will do low phospholipid reagent so that DRVVT will be prolonged. When you replace it with a high phospholipid reagent, that will get shortened. Okay. So that is all. For this case, we didn't get the follow-up. We are planning to start lupus soon. And the take-home message, hemostasis depends on thrombin generation occurring over the surface of platelets. Bleeding history is more important than the laboratory value, and prolonged APTT doesn't always mean bleeding risk. Contact factors, 12, high molecular weight kininogen and prekallikrein are just laboratory phenomena. They are not required for in vivo hemostasis. Low factor rate levels are not always due to hemophilia A. 1 Willebrand disease and acquired hemophilia should also be kept in mind and interpreted based on the clinical context. So to conclude, the challenge is not identifying a prolonged APTT, but understanding what it actually means. Every prolonged APTT is either a panic, puzzle, or a pitfall, and our job is to classify it correctly. So these are my acknowledgements. This is where I started my journey. And all these institutes, now I am in Calicut Medical College. And thanks to all the coagulation team where I worked. And some of the cases were shared from the places where I worked. Thank you.
So quite difficult to understand all this, and getting into the in-depth is also very, very difficult. And we have, as I already said, we have acquired a coagulometer IL laboratory for doing a whole battery of tests. But I don't know how much of in-depth each of us can actually do. Now that Pranav is there, it can all be done in the correct QC and everything. We've got it to the lowest rate. But I hope he'll always be around without getting transferred, because it may be difficult for each person. We always have a rotation system.
Once the technicians get trained, like it will, once they are enough exposed to the cases, and when we get enough cases and technicians get trained, they'll be able to.
Interpretation part?
Once the procedure is done correctly, history is taken correctly, procedure is missing.
I think it's just like slide discussions. It's important to have coagulation exercise discussions. We used to have it, if you remember. I think when you were PGs, we used to have coagulation exercises. We'll give a sheet with all the history, and you have to discuss.
And that is very much required because our residents are not.
We used to do this even at a time when we didn't have the machine. Machine, I think we bought in the 2009, I think. Stago. 2009 we got the Stago. Even before that, we used to have these discussions. So that's very important. It's as important, just like you have the slide discussion in hematology. Like
maybe we can do a Friday discussion, allotting cases to PGs and Girish. ഇതിലിപ്പം കുറെയൊക്കെ നമ്മുടെ കേസാണ്. പക്ഷെ നമുക്ക് ഫോളോ അപ്പ് ഒക്കെ പല സ്ഥലത്തു നിന്നൊക്കെ കിട്ടിയതാണ്. പക്ഷെ ഇനീഷ്യൽ 7 കേസിൽ 4 കേസസ് നമ്മുടേതായിരുന്നു, 3 കേസ് പുറത്തുനിന്ന്.
അടക്കം ഇവിടെ ചെയ്യാൻ ആയിട്ട്
ഉണ്ട്. സിസ്മാക്സ് ആക്ച്വലി അവർ സീമെൻസിന്റെ റിയേജൻസ് ആണ് യൂസ് ചെയ്യുന്നത്. അത് വാലിഡേറ്റഡ് ആണെന്നാണ് അവർ പറയുന്നത്. ചെയ്യുന്നത് നൗ നമ്മളിപ്പോൾ കോട്ട് ചെയ്തപ്പോൾ ക്രോമോജൻ ആക്ച്വലി 600 സംതിങ്ങിൽ കിട്ടിയിട്ടുണ്ട്. ഇപ്പോൾ നമുക്ക് പുതിയൊരു കോട്ടിൽ പെർ ടെസ്റ്റ് 600 ആണ് അവർ പറയുന്നത്. സോ അങ്ങനെ ഇപ്പൊ പുതിയൊരു വേർഫൻ എന്ന് പറയുന്നത് 600 നമുക്ക് ചെയ്യാൻ പറ്റിക്കഴിഞ്ഞാൽ നമ്മുടെ പേഷ്യൻസിന് ഭയങ്കര യൂസ്ഫുൾ ആയിരിക്കും. കാരണം പുറത്ത് ഭയങ്കര ഹൈ എമൗണ്ടിലാണ് ഇപ്പോൾ ചെയ്തു പോകുന്നത്. അതെ, നമുക്ക് പൂൾ ചെയ്തിട്ടേ ചെയ്യാൻ പറ്റുള്ളൂ കറന്റ്ലി. പക്ഷേ മാഡം ഇപ്പോൾ 18 ഇയേഴ്സ് വരെ ഇത് കിട്ടുന്നുണ്ട്. ഇനി പതുക്കെ അഡൾട്ട്സിനും ഒക്കെ കിട്ടിത്തുടങ്ങും എമിസുമാബ്. സോ അന്നേരം നമ്മൾ ഇനി APTT ബേസ്ഡ് അസേക്ക് റോൾ ഇല്ലാതാവും. യു ഹാവ് ടു ഷിഫ്റ്റ് ടു അപ്പോൾ കേസും കൂടുതൽ വരും. കറന്റ്ലി നമ്മളിപ്പോൾ വരുന്നത് പൂൾ ചെയ്യേണ്ടി വരും. Come down. We had one case where he was posted for surgery, and we had to arrange dry ice and all to transport the blood to Amrita and get this chromogenic assay done. So it's quite difficult for our patients. So it's high time that we have to. ഇപ്പം അവർ കോട്ട് ചെയ്തിരിക്കുന്നത് അറൌണ്ട് 600 ആണ്, 577 സംതിങ് ആണ്. അത് റെൻ്റലിൽ കോസ്റ്റ് പെർ റിപ്പോർട്ടബിൾ ടെസ്റ്റ് ആയിട്ട് അവർ തന്നിട്ടുള്ളത് ഈ റേഞ്ചിലാണ്. സോ പൂൾ ചെയ്ത് കഴിഞ്ഞാൽ നമുക്ക് ചെയ്യാൻ പറ്റും.